Good morning, everyone. This is Lana Comstock calling in here with the Opioid Guardianship webinar. What a beautiful day today. It's Monday, and I'm sure we all had a busy weekend. Looking forward to getting things started. I appreciate the fact that you could join us for our rescheduled webinar, and we are getting a lot of people that are still joining us. Just a couple little reminders as we get started here. We will be recording our call, and this will be posted on our Innovation site. In addition, we will have transcripts, and it does take a few days for us to obtain all of that and have that on our site. So it is helpful for us to look back. I know a lot of us are using these webinars to work within our own teams as we work on our stewardship program for opioids. Please remember to keep your phone line muted and don't place your phone on hold so we will not have that background material occurring. Also, if you have a microphone in your computer and you are using the telephone, then we sometimes get some background noise. So just a reminder to use one or the other. We're going to try to have some interaction with our webinar presenters today. So please feel free to utilize the chat box, and we will take a look at questions, comments at the end of the presentation. And let's just try to be as interactive as we can. We're going to have an exciting webinar today. And next, I'm going to have the opportunity here to introduce our speakers. Our webinar today, Patient-Centered Care, Monitoring and Disposal. And I have the distinct pleasure of introducing Andrew Funk, Executive Director of the Iowa Board of Pharmacy, as well as Jennifer Tiffany, Associate Director of the Iowa Board of Pharmacy. And she's working with the Prescription Monitoring Program. And I just want to say thank you so much to both of you for joining us today and presenting on the Prescription Monitoring Program, the disposal of controlled substances, and then just providing us with an update on what's happened with the opioid legislation. So please let me know when you would like me to advance your slides, and I will now turn it over to you.
Thank you, Lana. Good morning, everyone, and thank you to the Iowa Healthcare Collaborative for hosting this webinar. And thank you to all that are joining us today. As Lana mentioned, my name is Jennifer Tiffany, and the Board of Pharmacy's Executive Director is joining me today as we highlight the state's prescription monitoring program, as well as our safe and responsible pharmaceutical collection and disposal programs. Next slide, please. So just a brief bit of history to start. Our state's prescription monitoring program became operational in March of 2009, and that was following legislation that had been passed in 2008 that enabled its creation. Aside from myself and another half-time PMP administrator, the program is guided by a governor-appointed PMP advisory council, and that 8-person council meets periodically and is comprised of 4 physician members, 3 pharmacist members, and 1 non-physician prescriber. And our current non-physician prescriber is a nurse practitioner. Council members look at program progress and budget, as well as options for enhancing the program. Any comments or suggestions related to the PMP are addressed by the council, and this includes items that would necessitate a rule change. And for those of you that aren't real familiar with the rule change process, any individual can submit a request for a rule change to the Board of Pharmacy. If there is anything that you feel should be added to the prescription monitoring program through rule that is not already there, we will take any information or requests that you have, and we can present that to our advisory council and then ultimately to the full board for looking at proposing rule changes that would incorporate those suggestions. So If anyone has questions on going that route, feel free to contact us here at the Board of Pharmacy regarding that. Next slide. Okay, thank you. With regard to the basic function and foundation of the PMP, it serves to provide authorized prescribers and dispensers with information regarding their patients' use of Schedule 2 through 4 controlled substances. As far as the data retention goes, the board's PMP program has the statutory authority to maintain that information for 4 years following the date that each qualifying prescription was dispensed. And then after that point, the data is purged from the system. Starting in 2013, our PMP started receiving controlled substance prescription data from our licensed non-resident pharmacies. And that was a big step, we felt, in helping to close a rather substantial data gap, which in turn allows the PMP to be a more complete and useful tool. We can go to that slide with the map, please. Thank you. So here we have a map showing where each state, as well as U.S. territories, stand with regard to having a functional PMP. One piece to point out, which is addressed in the fine print at the bottom, is that Missouri currently does not have a statewide PMP, although various counties and municipalities within the state have PMPs. And that currently covers 79% of the state's population, which, looking at where they were a year ago, where they didn't have anything, I think that's a pretty great accomplishment. Some general goals of any PMP or PDMP are to improve opioid prescribing by providing critical information regarding a patient's controlled substance history, and to inform clinical practice by identifying patients at high risk who would benefit from early interventions, and then finally to reduce the number of people who misuse, abuse, or overdose, while making sure that patients have access to safe and effective pain management. Next slide. So our next map here shows variations in the type of information collected by each state's PMP. This time, there are 15 states that require information on drugs in Schedules 2 through 5 to be submitted, and then 21 states that require Schedules 2 through 5, and then what are broadly referred to as drugs of concern to be reported. Examples of drugs of concern include gabapentin, human growth hormone, cyclobenzaprine, and naloxone. You can see Iowa is trailing in terms of its range of schedules required to be reported, in that we only require Schedules 2 through 4. No Schedule 5s or drugs of concern are required to be reported at this time. The Board of Pharmacy did introduce legislation this session that would have required Schedule 5 data to be included, but that bill did not make it through. We will plan to put it out there again next year with the hope that it will gain some traction next session. Next slide. And then this is just more of a regionalized map that shows the disparity between prescription data required to be recorded in surrounding states and that which is required in Iowa. Again, Iowa lags behind with Schedule 5s. But the case for adding a drug of concern like gabapentin would be helpful in helping create a fuller picture and allowing for additional data to be used in measures to drive positive results from the PMP. Next slide. Data reporting requirements. On Wednesday of this week, the 16th, the frequency with which data must be required to be reported to the Iowa PMP will change. Historically, we have only required weekly reporting to the PMP, but starting Wednesday, each pharmacy will be required to report qualifying prescriptions no later than the next business day. A good portion of Iowa licensed pharmacies have already been reporting that frequently by choice. So while this change will be quite novel for some, it is not at all foreign to many of our licensees. The daily reporting is still a requirement even if a pharmacy does not dispense any Schedule 2 through 4 prescriptions on a given day. That pharmacy must submit what we call a zero report for all dates where they had zero applicable activity. Next slide. And then this map does a nice job of showing how Iowa is falling in line with the vast majority of other state PMPs with regard to that reporting frequency. In April, the National Safety Council issued a news release stating that only 13 states in the District of Columbia were adequately addressing the opioid crisis. Iowa was not one of those states, and we were actually one of 8 states that received a failing mark. It's my belief that beefing up our PMP program and coming in line with those 13 states is happening, which is evidenced by changes such as the reporting frequency. Next slide. So if a pharmacy does not dispense controlled substances to patients in Iowa, or if they believe they are exempt from reporting to the Iowa PMP, that pharmacy may submit a request to be approved for a reporting exemption. Other than pharmacies that don't handle any types of controlled substances or don't ship controlled substance prescriptions into the state of Iowa, examples of who might submit a request for a reporting exemption would be pharmacies that are dispensing to patients as part of a narcotic treatment center, sometimes referred to as methadone clinics. They are exempt. Pharmacies that only dispense controlled substances to inpatients of a long-term care facility or an inpatient hospice are also currently exempt. They will apply for that waiver, and then if approved by our board, that waiver does not expire. We do ask any licensee that has a current exemption in place that if their business practice changes, that they would need to immediately identify us of that change in business practice so that we can start monitoring their submission of required reporting. Next slide, please. So let's take a look at who can use the Iowa PMP. Right now, we have approved users, which we kind of lump together into 2 categories, referred to as the prescribers and the dispensers. Prescriber is a licensed healthcare professional who also has the authority to prescribe controlled substances. So any medical doctor, DO, PA, nurse practitioner, podiatrist, list goes on. If they have a DEA registration, they are eligible to apply for a user account with the Iowa PMP. And a dispenser right now only means a pharmacist, but that is going to change when the opioid bill becomes effective. And it was announced this morning that Governor Reynolds will be signing the opioid bill into law today. If you're unfamiliar with the opioid bill, when Andrew speaks here shortly, he's going to talk a little bit about it and how it relates to what is required of dispensing practitioners who, once that bill is effective, they will also be required to report any data on controlled substances that they dispense out of the office or clinic practice. Next slide, please. So other approved users include law enforcement and regulatory agents. Although these users must present a court order or subpoena to us in order to obtain information, and that has to be on a specific individual that they are actively investigating. They can't go on fishing expeditions, and we closely scrutinize the subpoenas that we receive with our Assistant Attorney General, just so we can ensure that the request does fall in line with our code and rule requirements, and that there has to be probable cause. Just going back a bit to the use of the PMP by prescribers and dispensers, they or their authorized agents, they may query for a patient's PMP reports only if they are currently providing care to that patient or if they're considering providing care to the individual. Next slide, please. And then another map here that shows how Iowa falls in line compared to the rest of the United States with regards to what we allow for law enforcement agents and regulatory agents to have access to. As you can see, we, along with the majority of states, allow reports to be generated and disseminated to those agents on patients, prescribers, and dispensers, so long as, again, they have the appropriate and required legal documents. Just as a reminder, I imagine several of you on the line are prescribers or dispensers. If you have access to the PMP and you run a report on a current or potential patient, as it stands right now, a copy of that patient's PMP report cannot be given to the patient. You can show a patient that report, but you're not allowed to physically hand over a copy of that patient's report to the individual. If a patient wants a copy of their PMP report, they have to request it via specific forms that are available on our Board of Pharmacy website. And once we receive that completed form, we will run that patient's report and then supply them with that information. So again, that's just a quick rundown on some very high-level points with our Iowa PMP, and now I'm going to hand it over to Andrew Funk, who will talk about our enhanced PMP platform.
Thanks, Jen. Good morning, everybody. This slide you see in front of you gives you a comparison of what the previous login screen looked like under our old OTEC platform and now the new Aware platform is to the right. One of the, probably the most exciting feature for us, at least within the office, is on that right, you see under password it says reset password. Under the old platform, in order to reset a password or unlock an account, you had to call our office Monday through Friday, speak to someone, and have that password reset. Now, with our new platform, you're able to reset that password. If you've gotten locked out or you forgot your password, you can do that without the intervention of staff. So that has really helped our internal processes, and we really hope that that is a feature that is expected and welcomed under the new platform. Next slide. So these are the upgrades. I already mentioned the password reset, the functionality for delegates to sign up for access to the PMP. That registration process is now done online as opposed to a paper application process. The interface has been upgraded, it's user-friendly. One of the other main features that the Aware platform offers is the unlimited integration capability, and I'll talk a little bit about that later on. It also has a built-in medication-assisted treatment locator tool, as well as educational resources that link to CDC recommendations and guidelines. We also offered the Narcs Care module, which is a data analytics tool for prescribers and pharmacists. And these essentially take all of the data, the dispensing data from at least a two-year time period, aggregate that data, and assign risk values and scores to patients. And if any pharmacies or providers integrate the PMP into their electronic health records, those scores, those values from Narcs Care are available without any click access. So they are just integrated directly into an EHR or pharmacy dispensing software. Next slide. Once you log in, you're taken to a dashboard screen. And as Jen mentioned, and I'll talk a little bit more about the opioid bill that will be signed into law today, one of the requirements is for our office to provide prescribers with annual report cards. Our hope is that we're able to work with our vendor, and rather than provide report cards on an annual basis, that if a provider logs in to the PMP, that basically that report information will be made available instantaneously on the dashboard. And what that report will show is a comparison of prescribing habits from peers, similar peers or similar practices. So a dentist would see trends or see aggregate information from other dentists that are practicing in the state of Iowa. This also shows a list. If you're listed as a delegate, it will show who your supervisors are. You can be a delegate for multiple supervisors, and those would all be listed here. And of course, shows your most recent requests for patient profiles. Quick links are to the right. We right now are linked to our Iowa Board of Pharmacy website, the DEA, and there is a NARCS Care training video as well as interpretation training video as well. And I think there's a quick link to run reports, so it's just right there on the dashboard. Next slide. To run a report, you just click on the menu, and then you can go over to RX Search and click on that patient request. Next slide. It'll take you to this screen. The top box there where it says Select Supervisor, that is only present if you are listed as a delegate user. So a delegate user would be anyone that a prescriber or a pharmacist has listed to have authority to access the PMP under their credentials. They have their own login credentials, but when they do process a request, they'll go up to that supervisor box and then pick the supervisor that they are performing the search under. So that supervisor would be selected, then the patient's first name and last name. We need at least the first 3 digits of first name, first 3 digits of last name, and then date of birth. And at that point, that's the minimum requirements for performing a search. Next slide. And scrolling down from that previous slide, this is the extended information that you'll see. The prescription fill dates, we have 4 years of data that you're able to go back to search. Right now, the minimum search requirement is 2 years. And the reason for that is because we've supplied the NARCS Care module, and it needs that 2 years of data in order to provide the analytics in those reports. Below that is the PMP Interconnect, and this gives you the capability of selecting additional states that you'd like to check. You'll note that we don't have all 50 states available. We do have the authority to connect with all states, but each state has their own individual law as far as who can access information and what information can be accessed. And so each state we have to individually set up data sharing agreements with in order for them to authorize us to receive data from that state and vice versa for that state to receive data from us. So the list you have there, since we've created this slide, we've also added Illinois and Wisconsin to that interconnect search. And I would note that that these states or the interconnects are not defaulted to check. You have to manually search or manually check the states that you'd want to search. And the reason for that is if we do get to the point where we're able to have 50 states out there, if we defaulted to every 50 state or every state, then each individual state then would be pinged when you search. And so this keeping it defaulted to just Iowa and then having you select specific states that you're interested in seeing helps cut down on the lag in the data receipt. So after you run the report, this is what the new PMP report will look like. And this includes the NARCS Care module. So with the NARCS Care module, probably the biggest change you'll see are those risk indicators. And you see the NARCS scores, You've got a narcotic score, a sedative score, a stimulant score, and then an overdose risk score, as well as additional risk indicators. And I'll just briefly talk about the NARC scores first. So you'll notice on this slide that the narcotic score is 420. That score ranges from 0 up to 999, and that's the case for all three of those scores. The narcotic score and the sedative scores, they do overlap. So if you have an individual that, say, is prescribed a narcotic but doesn't have a benzodiazepine, it is entirely possible to have a sedative score and that person not necessarily be on a benzodiazepine. The last digit in those scores are probably one of the most important factors to these scores. That last digit, whether it's narcotic, sedative, or stimulant, indicates the current active number of prescriptions that patient has been dispensed. So for example, in this case, the score of 420, that 0 would indicate that whatever prescriptions that patient had for narcotic, that supply has been exhausted. And so if that were a 1 or a 2 or a 3, the higher that number, the more active prescriptions that patient would have. So if you had a narcotic score of 423, then that individual has had a report of 3 prescriptions that are currently active, meaning the day's supplies that were submitted by the pharmacy has not been exhausted. And so that particular attention should be paid to that last digit in instances on making a determination whether or not to dispense additional opioids or prescribe an initial opioid therapy. Again, the higher the number, the greater the risk, and we'll talk about where these scores came from and some of the data behind it. Next slide. So I talked a little bit about that, what NARCS Care is. It is more of a substance use disorder prevention and management platform, and it takes a look at PMP data, aggregates it, and it helps prescribers and pharmacists to identify and manage substance use disorder. Takes that information and makes it more readily accessible. Again, the NARCS Care scores can be integrated directly into EHRs and PDSs. And again, the 2 types of scores are NARCS scores and the overdose risk score. One thing that I want to point out about those scores is the scores are just numbers, and they can't be used alone to make a clinical decision on whether or not to start, continue, or discontinue a controlled substance. What they should do, though, is provide the prescriber and the pharmacist with an opportunity to initiate a conversation or discussion regarding a patient's use and appropriate therapy given the substances that the patient's on. So again, the scores are another tool. It's something to help readily identify a potential issue and to help have that discussion with patients regarding opioid and controlled substance use. But the score alone can't be used to make a clinical decision. So this is the analytic report again, and we've just circled up at the top here that there is the capability of printing and downloading the NARCS report. And a couple things to point out, I think Jen already mentioned it, is that this report, while you can print and download it, we're not able to disclose or hand copies of those reports to patients or share those reports to other individuals, except in the cases of in which a provider and a pharmacist are working together in the care of that patient. We do get questions quite a bit, quite frequently, regarding whether or not reports can be downloaded and then uploaded into an EHR. And while that's entirely possible, I think we kind of discourage that practice just based on the fact, and especially now with the analytics, these numbers are not static. They continuously change, and so uploading that information into an EHR may become dated within a day or two and not provide the same value. It would provide you a snapshot on what you utilized at that particular time and as part of your clinical decision making, but unless you're able to somehow have your EHR lock out who has the access to that document, we generally discourage the scanning and saving of that document into the EHR. And running the report, again, if integration is done, it's a click of a button, and it saves quite a few keystrokes as opposed to saving and uploading the document. Next slide. So the NARC score, the scores and the overdoses, or the overdose risk score, they range again from 0 to 999. And you take a look at how those scores are calculated, and clearly, it's taking into consideration things like number of providers, number of pharmacies that have been visited within a period of time, your milligram morphine equivalents, and then any overlapping prescriptions. And those last two, as far as how they are weighted in developing that score, are more heavily weighted than the number of providers and pharmacies that the patient's seeing. So as that score increases, then clearly the number of providers, pharmacies, morphine milligram equivalents, and overlapping prescriptions also increase. Next slide. So three of the factors are patient behaviors. And those are things like visiting pharmacies, multiple pharmacies, going to multiple providers, or having multiple controlled substance prescriptions that are overlapping at the same time. So we look at those things as a behavior of the patient. And then we also, what NARC's Care does is it takes a look at the morphine milligram equivalents. And so if you've got a low MME and you're using one pharmacy and you're one provider and you don't have any overlapping prescriptions, you would expect your NARC score or your narcotic score to be relatively low. And that's indicated there in the chart. And again, as you increase on the MMEs and you increase on those behaviors, then that score is subsequently going to increase. Next slide. This is a population distribution, what you should expect in just an overall state of where patients should fall as far as what the scores and NARC scores should be. So in 75% of the population, your score is going to be less than 200, and only about 1% will have a score above 650. And so spending a little bit more time with those patients as those scores go up would be prudent. The overdose risk score is a predictive score for unintentional overdose death, which is based on a study in Ohio that evaluated 1,687 unintentional overdose deaths in the year 2014. The study looked at 70 variables and evaluated that in the creation of the overdose risk score. And out of the 70 variables, 10 were chosen to form the model that based the independent predictive availability. Some of the factors, again, included the number of provider and pharmacy visits within a specific time frame and the morphine milligram equivalents that were dispensed within that time frame. And I'll note that we'll go back to that. Well, I guess the next slide actually takes that. Yeah. These overdose risk scores, they've been developed so that each increment of 100, it essentially doubles the risk of unintentional overdose death. So looking at a score that is between 0 and 200 compared to a score that's above 900, the risk of death for someone with a score of 900 is 329 times more likely than someone with a score of under 200. And on our website, there is available recommendations as far as guidance on if scores fall within this certain frame, what type of recommendations might you want to consider. And so, for example, if you had someone in a range of 500, their overdose risk was in the range of 500 or higher, it might be something where the pharmacist would want to initiate the discussion of naloxone therapy, suggesting perhaps maybe the patient receive a naloxone kit in the case of an overdose it was warranted. Next slide. On the right, far right, there are additional risk indicators, and right now the platform has 3 additional risk indicators, or ARIs. Those are whether or not the patient has 5 or more prescribers within a year's time frame, 4 or more pharmacies within a 90-day period, or more than 40 milligram morphine equivalents per day average, or more than 100 morphine milligram equivalents total that were dispensed. And these ARIs within the PMP data have been shown to be predictors of adverse outcomes, specifically unintentional overdose death. The PMP-based ARIs used by NarxCare were studied alongside the NarxCare narcotic score as a predictor of unintentional overdose death. And so if all 3 of those additional risk indicators are present simultaneously, then it's functionally equivalent to an overdose risk score of 650. This section of the NarxCare report is also designed by the vendor to supply non-PMP related risk indicators as they become available. Some of those indicators could include whether or not the patient has a history of substance use disorder, if they have a history of medication-assisted use or medication-assisted treatment, a history of heroin or illicit opioid use, or if they've been previously administered naloxone. And that's one of the requirements of the House File 2377, that naloxone administrations be reported to the PMP and by first responders. So that information will be an additional risk indicator which will be populated here, and will show whether or not the patient has had a naloxone administration actually administered to the patient. Next slide. PMP integration. This is, I think, the most important feature of the AWARE platform. We have unlimited capabilities for integrating right now. Under the old OTEC platform, integration was possible, but the problem with integration, I guess if you want to call it that, is that the use of the PMP goes up dramatically. If we take a look at Ohio, back in 2011, they had about 88 million, 1.78 million queries to the PMP. And then in 2017, the state of Ohio rolled out a statewide integration. So the state is actually funding integration for all platforms and pharmacy dispensing systems. They saw an increase of 5,000% of the number of queries that were made to the PMP. So in 2011, prior to integration, they had 1.78 million queries, and then in 2017, that jumped up to 88.96 million queries. And so under our old platform, just the way the data flowed back and forth between pharmacies and the platform, the database, and then from the database into the providers, had we seen that market increase in the number of queries, the platform just simply wouldn't have been able to handle it, and we would have gone down. And so with this new platform, the way that the data migrates and the way the data is shared, it's different, and so we're able to integrate with whoever is interested in doing that. One of the key features of the integration, again, is your one less password that you've got to remember, your one less username that you've got to remember. If you're logged into Epic or you're logged into your pharmacy dispensing system, you're able to have one-click access to the PMP. And because we did offer NARCS care, then those scores are immediately available within workflow. And I've got some examples of what that looks like, I think, on the next slide. Yep, go ahead and advance the slide. So this is just the generic EHR and what it would look like if we had if you integrated with the PMP. So notice that right there in the chart summary, right there on the front page, you've got access to those numbers. And obviously in this example, we've got a narcotic score of 633. That 3 is indicating that there are 3 current active prescriptions that have been dispensed to that patient, and that should initiate a conversation to take a look at what's going on in that patient's life. And of course, the one-click access to show report is available right there within the chart. Next slide. Same thing for pharmacy. This is our just a generic version of a pharmacy dispensing software. Again, you've got the scores right there, as well as those alerts that are available. Next slide. These are all the current existing interfaces, and what this means is these platforms already have a built-out capability to directly integrate PMP data with the system. So I would point out that we've got Cerner and Epic on this list. Those are kind of the most, at least from what we've dealt with, maybe the most have the largest footprint in Iowa as far as electronic health records. So if that integration already exists, you're able to immediately get this information instilled into your software. On the right, we've got existing interfaces for our pharmacy dispensing software, and Pioneer and QS1 are some of the RX30 are some of the more common ones on that list. So again, these are there's no additional cost as far as startup costs for any providers that are using these systems. It's just a matter of essentially flipping a switch, signing a couple documents, and having that information immediately within your system. Next slide. So how do you go about doing it? I think the very first thing is just consider the financial commitment. And if you are a medical provider, your fees are anywhere between $45 and $50 per prescriber per year of access. So if you are a solo practitioner and you say you're utilizing Epic and you wanted to integrate, your cost would be roughly $50 per year to have that information accessed and integrated into the EHR. On the flip side, for the pharmacy dispensing software, there is an annual charge of $120, and that's per pharmacy per year of access. And so not specific to the pharmacist, but to the store. And so that $120 provides you with that no-click access to the NARCS care report within the pharmacy dispensing software. Again, now on that previous slide, we highlighted which platforms currently had an established interface. And if that's the case, then these would be the steps that you'd want to follow in order to get an integration started. Jen Tiffany, who's presenting today, is able to help facilitate that process, and you're also able to connect directly with our vendor, Apris Health, and they've set up a specific email an email address specific to Iowa users that are interested in integrating, and an email can be sent there. We do currently have a data sharing agreement that the board asks the users of the PMP to execute prior to integrating. We're reviewing that right now, and we're unsure if that's going to be a necessity in the future. But in the interim, we do have a data sharing agreement, which Jen Tiffany can provide you a copy with if you just send her an email. Next slide. So these are the steps if there is not an established interface. So if you've got a software, and there are various software systems that are in the varying processes of development on whether or not the integration is being built or in the process of being built. But if it's not been yet established, then there's an additional step, an additional financial impact and commitment. And you'll notice that I think I left that out on the PDS side, but you also have that possible additional one-time startup fee if that vendor is not currently established as an integrator or as a built-out interface. So that one-time fee would be assessed by APRIS, and anywhere from what I've heard about $8,000, give or take, to establish that interface. And again, you can reach out to Jen Tiffany to get a copy of the data sharing agreement, and then start working with APRIS. You'd want your IT folks to start working with APRIS to get that interface built. Next slide. So the opioid bill. Jen had mentioned that the governor is planning to sign this bill into law today, and just want to highlight some of the things that will be happening with that bill and some of the changes and how it will impact our PMP. The first thing, and I already mentioned it, naloxone dispensings, which will be reported under patient profiles by pharmacies, will be reported to the PMP, as well as first responders. So EMS, law enforcement that are actually administering these products to patients or to individuals they're assisting, those will also be reported in a different manner. And I already mentioned that those will show up as a ARI within the platform of NarxCare. It also codifies the board's rule that requires next business day reporting to the PMP, which is effective this Wednesday, May 16th, 2018. And it requires the dispensers to report no later than next business day any dispensings of controlled substances that are required to be reported to the PMP. Registration for providers becomes mandatory, as well as utilization, and that's pursuant to board rules. And so the various prescribing boards will be tasked with developing rules to govern when it will be appropriate in the particular situations in which a PMP must be queried. And so those individual prescribing boards will be the primary overseers of that enforcement. When right now, I think last year in our annual report, we had about 47% of our prescribers that were registered to utilize the PMP. This bill effectively will get us to 100% of the providers registered with us. We renew controlled substance registrations every 2 years, and so within the next 2 years, the way this bill is written, we'll have 100% registration with the PMP. And this bill also gives the Board of Pharmacy the authority to provide prescribers and dispensers with proactive notifications. If you remember, under the old platform, there's a capability of receiving notifications, but those notifications were very general. They were very non-specific. And what this legislation allows us to do is to actively identify those patients that are being treated by a specific provider or a pharmacy is dispensing to, in which there may be red flag behavior. We'll work with our advisory council to determine what those triggers should be. But essentially, if you can think of, a patient visiting X number of providers within X days, or utilizing X number of pharmacies within Y days, or receiving certain morphine milligram equivalents, then we will have an opportunity to provide the prescribers and pharmacists with an alert, just letting them know that some of these risk indicators are present, and that taking a look at the PMP may be appropriate. I think that covers my part. Jen's got a a little bit a discussion on the medication disposal program that the board operates, so I'll turn that over to her.
Thanks, Andrew. So now we're going to shift gears a little bit and talk about the responsible medication disposal, which, in my opinion, really goes part and parcel with addressing the opioid crisis. And I say that because about 1/2 of individuals who misuse prescription pain relievers obtain them from a friend or relative for free. So we need to improve access to responsible drug disposal options so that patients who have leftover, unused, unwanted controlled substances, and we're not just talking pain relievers, can get those items out of their home or out of their possession. And there are a variety of ways that patients can safely dispose of their medications that they no longer want or need. Next slide. So the first option is limited to the disposal of non-controlled prescription drugs and over-the-counter medications. The program is run through the Iowa Pharmacy Association and is funded by the Board of Pharmacy. So if a pharmacy wants to participate and receive a disposal box from IPA is currently partnering with Eco-Returns, then they would simply need to contact the Iowa Pharmacy Association to get started with that. Next slide. So the Eco-Return boxes are essentially just sturdy cardboard boxes that allow for the disposal of these types of items on these lists, and that includes any unused, non-controlled prescription pills, capsules, tablets, as well as any topical preparations such as lotions and creams. Inhalers and nebulizers are also allowed to be deposited in the boxes, as are liquids, but it is just recommended that if you are placing any liquid into one of these disposal boxes, that you place it in a plastic bag prior to placing it into the receptacle. Again, no controlled substances are allowed in these boxes, and it's also impermissible to place any type of sharps in there. So the next option that pharmacies are able to take advantage of is that allowing for end users to get rid of both controlled substances and non-controlled substances. And I think it's important to define what constitutes an end user or an ultimate user, as the ultimate user is the one who must place their medications into one of these DEA compliant receptacles. As you can see, ultimate user as defined by federal code is a person who has lawfully obtained and who possesses a controlled substance for his own use or for the use of a member of his household or for an animal owned by him or a member of his household. So another program our Board of Pharmacy funds is placement of what we term the DEA compliant disposal receptacles. And those are going into community pharmacies and also into hospitals with an inpatient pharmacy. Currently, we have a contract with a company known as Assured Waste Solutions, who manufacture the units. And they, being Assured Waste, refer to the receptacles as their MedDrop units. And to date, the Board of Pharmacy, we have purchased 100 units that have been installed at pharmacies and hospitals across the state. And then starting July 1 of this year, we will be able to fund placement of another 50 units to in-state Iowa licensed pharmacies that are interested. So what does an interested pharmacy need to do to get a MedDrop unit? The first step is to contact me to see what the current availability of units is. Right now, I already have a list of close to 25 pharmacies. It's a wait list for when our fiscal year starts July 1 and we can start ordering more of the units. So if you know of a pharmacy that would like one, the sooner they can contact me, the better, but they'll have a chance to get one of those units between July 1 of this year and then June 30th of 2019. Step 2 involves the pharmacy logging on to the DEA website, and when they get there, they'll need to modify their status with the DEA. It's a very simple process. They're just basically clicking that they're no longer just a pharmacy, but they are a retail pharmacy collector or a hospital pharmacy collector. There is not any fee to change the status with the DEA, and it is automatic. So after the states modify that DEA registration, they can download and print that updated DEA registration certificate that indicates they now have that collector status. And then a copy of that DEA certificate would need to be forwarded to me. And then once I have all of the documentation, then I can order the units from Assured Waste, and they typically ship them out typically within 1 week of the order being placed. So it's a pretty quick turnaround. These are just the dimensions of the current MedDrop containers that we're placing. They're approximately the size of just a standard United States Postal Service mailbox. And once the pharmacy or hospital receives the receptacle, they are required to install the unit. And it does have to be bolted to a permanent fixture, typically a floor or wall. Again, the responsibility for the installation is that of the pharmacy that's obtaining the box. We do have one installed here at our Board of Pharmacy office, and just from watching the installation of that, it's a fairly straightforward process. It's not overly onerous. So the DEA, via the codified federal regulations, they do require that the authorized collectors, they do have to maintain specific records. Then the first requirement in the CFR that relates to the pharmacies and record keeping with these units is that when the pharmacy takes their annual inventory, they do have to include the possession of any of the unused, what we call inner liners. And then they also have to include in their inventory, if they do have a full inner liner that they have sealed that is still awaiting pickup to be taken for ultimate incineration, that also needs to be part of the pharmacy's annual inventory. So until those leave the pharmacy, that has to be marked down with every other controlled substance that the pharmacy has in stock on the day that they do their inventory. Next slide. And then the DEA is also going to require the pharmacies to keep track of the dates that they receive any inner liners, the date that they install the liners into the surrounding receptacle, and when they remove them. And each of these inner liners, they're just very sturdy plastic bags. Each bag does have a serialized number imprinted on the bottom of it. And then each inner liner also has to be secured shut with a serialized zip tie. And so record keeping on those serial numbers does need to be maintained. And in terms of checking the units and packaging full liners, we can go to the next slide. This is just an example of what the units look like. This is obviously not a secured one. We do have this one open, but you can see there's an inner cardboard box and then the gray inner liner. Anytime that a pharmacy is checking the fill level of a MedDrop unit, there does need to be an additional person with whoever's opening it. There always has to be two people working together when anything's done with these inner liners. And the identification of those two people does need to be included in the required paperwork that the pharmacy will be maintaining. And on the next slide, there's just a sample of what Assured Waste Solutions does provide for any pharmacy that receives one of the receptacles. And it goes through and it kind of helps guide them through the information that they do need to keep with regard to the liners and the serialized numbers that are assigned to each of those. And you can see the last two columns do require the double signatures of the employees that were involved in any of those functions. So the Office of Drug Control Policy maintains a really nice map that anyone can go to through their website, and it will show all the pharmacy locations throughout the state that have a DEA-compliant controlled substance receptacle. And then there are also icons for where the law enforcement facilities in various counties have a receptacle as well. And so we just keep that up to date, and it's a nice way for anyone to see where the closest unit is to where they live. We do have all 99 counties covered, whether there's a unit at a law enforcement or at a pharmacy. And again, we'll be adding 50 more pharmacies to this map for this next fiscal year. So we're just gonna keep placing them to whoever would like them. So again, if you're interested, you can just contact me and I will get you on that wait list. So I think we're about an hour in, and I know that Lana was going to have some questions for us to address, and we'd be happy to answer anything that you guys are interested to know more about.
Well, we'll go ahead and ask folks to go ahead and type into the chat box if you have any specific questions. A couple of things that come to mind for me, and would like to ask you to address is, are there incurred risks for pharmacies who are actually taking the drug returns? Specifically, are there theft concerns with having those take-back containers?
I know that initially that was a common concern of pharmacies. They were reluctant that it would be an additional risk for theft, burglaries, but there hasn't been any data showing that pharmacies that have installed these units are a larger target for any theft or robberies. I think part of that is because not only are there, is there ability for controlled substances to be in there, but non-controlled too. And I feel like it would be a very unwise target for someone to try and get into one of these and get the bag out, because there could be no controlled substances in there. The only event that we have seen since we've started this program is that after the common carrier picked up one of the full receptacles from a pharmacy, the contents of the box were lost in transit before they got to back to Assured Waste, who would then transfer that on for incineration. And the responsibility at that point, the pharmacy would be responsible for submitting a theft or loss report to the DEA. But I did speak with our local DEA representative, and they wanted me to know and to be able to pass along to pharmacies that although the pharmacy is the required entity that has to submit that theft or loss report to the DEA would be using the information from that report to see whether there are trends with a specific carrier. So is it FedEx, is it UPS? And that's why they want that data. It's not as if they're going to come back to the pharmacy, because obviously once it's in the hands of the carrier, and the carrier misplaces it or loses it, the DEA is going to look down the line toward that common carrier versus at the pharmacy.
Sure, that only makes sense. So thank you for that. One comment here is it appears that maybe someone has a take-back disposal container, and the question then becomes, who do we contact if there is a take-back disposal container, but it's not on the map that you shared earlier?
Oh, certainly. They can contact me by email or by phone, and I will update the Office of Drug Control policy and get that unit onto the map. They take updates regularly, and they're really quick about getting those additional sites onto their website. So whoever has that can certainly just give me a buzz or email me, and I'll get that information over to ODCP.
Perfect. Another question is there any monitoring as to who and what is being put into the controlled box for take back?
No, and that's part of the Code of Federal Regulations, is that the items in those boxes is not to be inventoried by anyone in the pharmacy. And I think that too was a concern when we started this program. I feel like some pharmacies thought, oh gosh, I'm going to have all this extra work that I need to do. I'm going to have to inventory to make sure that there's not things put in there such as illicit drugs or sharps that shouldn't be. But the DEA is very specific in that you're not to go in there and try and inventory to see if there's something that should not be in there.
Thank you. I think that's a good point that you bring up, and kind of makes sense, doesn't it? Another question is, we had a situation come up this morning that a person is actively drug seeking. How can we communicate this to other providers and or pharmacies that this is happening now, since the alerts aren't an option any longer? Email alerts.
So yes, we did have the patient alert feature on the previous OTEC platform, and that received some mixed reviews because we weren't able to really tailor who receives those alerts depending on where they were located in the state. So ACRIS, our vendor for the Aware platform, has informed us that come Q3 of this year, so we're looking hopefully by the end of September, they will have an alert feature, peer-to-peer communication tool that will be available to all of the users. So that is coming, and I understand we have been getting numerous calls from individuals that would like to post an alert of some sort, and we're just not able to do that at this point, unfortunately.
Thank you, Jennifer. Another question is, will hospitals be required to report when they give naloxone as a reversal agent to the program?
Yeah, that's a really, really good question, and I'll maybe go on a little further to that point. The House File 2377 strikes out the required or the exceptions of required reporting. And so the section now reads that this section shall not apply to dispensing by a licensed pharmacy for the purposes of inpatient hospice care or long-term residential facility patient care. And so they've struck from that section of code the exception of prescribing practitioner that's furnishing, dispensing, supplying, or administering to the prescribing practitioner's patients, as well as inpatient hospital care. And so while your individual administrations from a nursing standpoint or from a physician standpoint most likely won't be reported in the same manner that first responders are reporting, those administrations that are part of the patient record for inpatient care or that are visited, that would be, in my interpretation, would be required to be reported.
Well, that's going to be a game changer for many hospitals.
Yeah, we understand that.
Will Just a quick question about the presentation being recorded. Some people always like to share the recording and then slide. And so yes, we are recording, and yes, it will be available. The slides will be in PDF format when they're prepared and posted on our site. Here's another comment. I'm in a small hospital that does not dispense to outpatients. It looks like we are eligible to be exempt from reporting CS RXs. Even if we are exempt, can we report anyway if we dispense a few tablets of something like tramadol from our ER? Can you see that one?
We can't.
I cannot see that.
Okay. Let me bring it over. Can you see it now?
No.
Okay. I do new share. So again, let me try to read that. It's in the chat feature. So being in a small hospital.
And I think I might be able to address that one. If there is an exemption due to the amount of controlled substance dispensed, but the pharmacy chooses to report that, they certainly can. We'll take those reports and we'll upload that into the database.
Thank you. Another question is, how do you know that a driver is trustworthy, and how is the container secured during transit?
Yeah, this is a great question, and you can't. We don't currently license what are called 3PLs, which would be companies like UPS. These are companies that take title to a product and but may not have ownership over the product, but it is in their possession. So in these cases, as far as third-party carriers and the 3PL providers, they're not registered or licensed with us. And one of the Board of Pharmacy's bills this year did introduce a licensing of 3PLs as a licensing category. And so our hope is in the future you're able to search the licensing database and information on those 3PLs to see which companies have had any issues with diversion or public discipline from our board.
But wouldn't it be true, this is my own question, wouldn't it be true that once the sign-off occurs, the liability with the pharmacy or hospital or whoever is turning that over, the liability ends for that person?
Yeah, what we've seen in the past, as far as diversions that do occur between a dispenser and either a reverse distributor or wherever that product is going, and it's ultimately discovered as being handled or diverted by that third party carrier. We typically see that that receiver of the intended receiver, whether it's being shipped back to the vendor, the wholesaler, or if the wholesaler is shipping to the pharmacy, we still need to have that loss reported. Whether it's done so by the wholesaler or done so by the pharmacy, I don't know that that's necessarily pertinent as far as who does it. It just needs to be reported. Once we do have the 3PL's license, then they would be responsible for that report as opposed to the way it's handled now.
Sure. Thank you. Here's a question. Can I, as a pharmacist, put an inpatient's controlled substance into a med drop RX located in our building with their permission, or would this violate the ultimate user rule?
We have received this question before, and I have checked with the DEA here at the local office, and they have indicated that only the end user can physically deposit a prescription into the med drop box. It cannot be put in there by a pharmacist or by any other employee at a hospital. So unfortunately, yeah, it's pretty pretty specific as to it having to be that ultimate user who performs the action.
Well, thank you. You've answered all the questions that we currently have posted. Oh, no, I just got another one in. How do they know that when a drop box is not monitored or audited as to who is putting meds in it?
Well, again, that's one that, you know, there's not a great way to audit that at this point. So, you know, I mean, I guess when it comes down to it, you know, I suppose, you know, what I look at is, do we want these medications safely disposed of? Ultimately, yes. And however it's getting in the box, yeah, we don't have the means to audit that at this point to make sure that it's, you know, things aren't going in there that a pharmacist is putting in there from their own pharmacy stock, or that a patient has essentially orphaned at the hospital. You know, so, I mean, I guess the bottom line is we're not, you know, I don't think the DEA has the resources either to audit that at this point. So I don't want to say it should be overlooked, because it should not, and we should all adhere to the rules that are in place, but there's not currently a way to tell if anything's been put in there by someone other than the end user.
Kind of an ethical issue.
Yeah.
Well, very good. What great information that you had today, and I know we have had a lot of engagement with our questions, so I do really want to thank you so much for taking the time to speak for us today. We appreciate it greatly. I'm going to just finish up with a few closing slides. I'm going to talk a little bit about our upcoming events, and we have this Thursday a training webinar that will have contact hours included. It is entitled Addiction Identified. Now what? So as a reminder, everyone can go ahead and register for that, and it is important to remember that in order to be allowed to have those continuing education credits, we have to have each person logged in as on their own email address. That'll become proof of the unique email that is going to be used for the continuing education. And at this point, we had 72 people who were registered for that event on Thursday. And that'll be actually our last webinar that we're going to be having during the course of our project. And then what we'll have are some virtual meetings for some data review and just reviewing where we're at with the project. I've had the opportunity to speak with many of you just in the last week about where things are at. We've talked a lot about your community meetings and getting people engaged and sharing the information that you have. A lot of you have already had your meetings, some have not, and that's fine. We just want to kind of track what it is that we have for our community meetings and the number of people who have been in attendance. So that's kind of what's been happening here. I'm just going to see if there's any further questions and take a look at the chat box one more time. And in closing, just so you know, we are here and we are available to you. Reach out whenever you'd like to. You can reach us at our email or telephone number. And again, thanks for joining us today, and we will see you on the webinar on Thursday. Thank you so much.